This conference will now be recorded.
Hello, everyone, and welcome to this webinar. The American Congress of Rehabilitation Medicine is pleased to present this Hot Topics in Complementary and Integrative Rehab Medicine webinar series. So we want to thank you for tuning in today, or for the many of you that will be watching this after the fact in our recording. I wanted to introduce myself. My name is Matt Erb, and I'm a physical therapist out of Tucson, Arizona, and am the co-chair of the Complementary and Integrative Rehab Medicine Networking Group webinar production team. So we're excited to launch this as the first of many webinars to support people in understanding the evidence base for integrative practices in rehabilitation medicine. Also with us today is Pei Shan, who is going to introduce herself next. She is my co-chair.
Hi everyone, my name is Pei Shan Wen. I'm the co-chair of the webinar production for the Complementary Integrative Rehabilitation Medicine Networking Group. And I'm also assistant professor at the Occupational Therapy Department of Georgia State University in Atlanta, Georgia. So for that, I would like to remind you, ACRM this year is gonna be in Atlanta, and they have two options just roll out yesterday. You can attend the conference in person or virtually. So I hope to see you there.
Great, thanks, Pei Shan. And as we're getting some slides up here for you, I want to review some housekeeping items for today. Please keep your phones and computers on mute, and this GoToMeeting system muted as well. Turning off alerts is also helpful so we don't have any background interruptions. We're going to have questions placed into the chat room. So any questions that you have, please type them into the chat room, and we'll have some time at the end to answer those questions. This meeting is being recorded, just to let you all know that, because we have a lot of participants who are only able to watch these webinars after the fact. Today's presentation is titled Merging Yoga and Occupational Therapy, and that's extrapolated to really merging yoga and yoga therapy into rehabilitation medicine in general. Our speaker today is Arlene Schmid, who's an associate professor at the Department of Occupational Therapy at Colorado State University. Dr. Schmid has been an occupational therapist for over 20 years, and her use of yoga in her clinical practice drove her to complete a PhD in rehabilitation sciences in order to develop and test yoga-based interventions for persons experiencing disabilities. Arlene is an associate professor at Colorado State University in the Department of Occupational Therapy, where she's completed many funded studies to explore the use of yoga with multiple diagnostic populations. She's currently funded by the NIH to merge yoga with education for people with chronic pain, and by the American Occupational Therapy Foundation to merge yoga and occupational therapy for persons with diabetes. She's mentored many thesis and doctoral students in yoga-related research and has nearly 100 publications, most of which disseminate yoga research. So we're going to turn this over to Arlene to talk to us today. Thank you, Arlene.
Hello, thank you, Matt. Thank you, Pei Shan, for the invitation to come and speak to everyone here. So we will just go ahead and get started. And I'm not always good at seeing what's happening in the chat and presenting, so I might need a little cueing for that. And thanks, Matt, that this talk really is about, it really stems from merging yoga and occupational therapy. And then towards the end, we'll talk about how we can change that or move that into rehabilitation in general. And we have many objectives today, so we will go ahead and get started. And we will move from things like considering yoga as a model of health and wellness, describing what yoga is, thinking about what yoga is compared to yoga therapy. We'll do a very short little review of the research specific to yoga and stroke. And then really we'll talk about 3 different studies that led us to merging yoga and occupational therapy. And we'll look at just some of the quantitative study results from that study. We could go on and on really hearing about all of the qualitative things that people had to say, but we'll, for this timeline, stick with just the quantitative components. And then at the very end, we will talk about how people can really integrate yoga into their clinical or rehabilitation practice. So thinking about stroke, just to kind of get everyone on the same page, there are about 800,000 new strokes annually in the United States, and close to 7 million Americans living with the effects of stroke. And we know the effects of stroke are many and include motor, sensory, cognitive, and emotional changes. We really here are going to focus somewhat on balance after stroke, because it's a little easier to start with some of the physical changes that happen, especially when we think about a randomized controlled trial, and really the first one to do with yoga. And so it's a little easier to think of how can we improve physical functioning versus also changing cognition and emotion and all of the aspects that make us a whole person. So when we think of balance after stroke, we know it's really common. We know about 76% of people report a fall after a stroke. And we know that balance is impaired both because of changes that occur in the brain with the stroke, but there's also all of these secondary changes that happen. So things like hemiparesis, so change in motor and sensory function on one side. We know there are changes to cognition and emotions that might even change balance and balance confidence. We also know that people who have worse balance tend to have worse quality of life after stroke. And we know all of these things related, fear of falling, fall self-efficacy, or balance confidence, all leads to increased fall risk. When we think of fall risk, or post-stroke falls in general, like I said, we know 76% of people report a fall after a stroke. So when I talk to clients, it's not really if you fall, it's unfortunately when you fall. And so we really talk to our students about this, right? We have to work on fall prevention, but we also have to talk to folks about what happens if you fall. When people had the stroke, often they fell with that stroke. And so they really develop a fear of falling that is associated with fear of another stroke, fear of another fall, but also fear of death, as some of them laid on the floor after their stroke, essentially waiting to die. And so it's a very convoluted, complex construct when we talk about post-stroke falls, post-stroke fear of falling, and post-stroke balance. We do know that folks who fall after stroke do have worse quality of life and activity and participation when we think of ICF language. We also know people who fall have worse occupational performance, depression, mortality rates, fracture rates, and general post-stroke recovery. So, of course, we think, well, we should work on falls and we should work on balance. And those 2 things are part of the current stroke rehabilitation guidelines. However, there's actually no evidence on how to best improve fall rates and balance after stroke. So when we consider all of the things that play into fall rates, that play into balance impairment after stroke, and think about older adults as well, it really led us to think about the possibility of using yoga to improve not only balance, but also balance confidence or balance self-efficacy, and then potentially fall rates as well. So we'll just talk a moment to get everyone on the same page about yoga. And we, of course, could have entire courses on this topic, but this will just be 1 or 2 slides. So yoga is an aspect of complementary and integrative health, and that's what CIH is, so complementary and integrative health. Yoga is considered a system of exercises for attaining bodily or mental control, well-being. It's dated, it's 5,000 years old approximately, and it is seen as a way to connect the mind, body, and the spirit. And it's been introduced into Western cultures, and it's really also here in the Western world seen as a way to also manage stress and improve health. This is just a link from the NIH, so you can think about or know about what NIH is saying, what yoga is, and the benefits related to yoga. There's actually quite a lot of research now that supports the use of yoga for different diagnoses, different populations, really with quite a large focus on yoga for chronic pain. When we think of yoga and the yogic philosophy, there are 8 limbs of yoga. And those are pictured here. And in the Western world, we often really think of yoga as asana, which are the poses or the posture. And so often when our folks think of yoga, if we just come and talk to someone with a stroke and say, do you want to do yoga? They kind of think this idea of a young, thin, white woman doing a handstand. And we really are trying to work to get away from that idea that asanas are part of yoga, but it's not all of yoga because there are these 8 limbs. Most people often also know about pranayama, which is working with our breath. And most yoga in the West also includes dhyana, the meditation. We typically don't meditate on the divine as we are state or nationally funded kind of work, but we do always include meditation and relaxation. What we also try to do in our research studies, though, is also include yamas and niyamas. And so there's a way to get at all 10 of those through our work with folks, even in group yoga. And a lot of things we do includes mantras. And so a good example here is that people with stroke are really attached to the person that they used to be before their stroke. And in yoga, we think, well, we shouldn't necessarily be attached to something, and we should try to be more in the present moment. So we might use mantras to include things like, I am enough, I am becoming enough, I am working on myself, things like that, so that people are a little less attached to the past or the future of what they want to be and help them stay in the current moment a little bit more. So we are rehabilitation therapists using yoga. There's also a group of folks out there who are yoga therapists, and I just thought it was important to bring attention to them. We often hire yoga therapists for our studies, but they are credentialed therapists who are very well trained to using yoga as therapy for people with disability. And so I think a very simplified idea is a difference between a yoga therapist and an OT or PT or RT using yoga is this idea at the bottom is a yoga therapist will use yoga as therapy. And often a rehabilitation therapist will integrate yoga into rehabilitation practice as one component of many things that we might be working on. But there are some websites there that might be helpful to you if you want to hear more or learn more about what yoga therapy is, the credentialing of yoga therapists, things like that. There are lots of questions in reality about yoga and why yoga works, and some of those questions are easier to answer than others. Some are certainly not answered at all. When people do yoga, you often hear things like, well, yoga changed my life, or I'm a better person because of yoga. And those are some big changes that we really, as researchers, are really, it's not very easy to collect data about how yoga changes one's life. But some things that we know or we think we know is that yoga really connects the mind and the body through breath work, so through pranayama. And it's very holistic. And for those of you who are occupational therapists, we're very much trained to be holistic practitioners and treat the whole person. And so I do think yoga and OT make a really nice fit. We know that the combination of yoga postures and breath work are more beneficial when those two things are combined. So it's more beneficial than just straight exercise and straight playing or using weights or TheraBand. We know yoga, that combination of postures and breath work is better, more effective than regular exercise. And part of yoga is really encouraging the mind to focus on what's happening in the current present moment and thinking about people becoming a little more aware of their own body. it's a practice to enhance our awareness. And so sometimes after a stroke, we'll even hear, or people with brain injury and things, we'll even hear people just becoming more aware of their body, maybe even feeling their body a little bit more or a little bit differently since the time of their stroke. We also know certainly that yoga changes the brain. We know yoga changes blood flow. There's different parts of breath work we can do, like alternate nostril breathing, that really changes breath in the moving the blood and the breath from hemisphere to hemisphere. And we're really stimulating both sides of the brain when we do yoga. All of our research has been with folks with chronic stroke, and so that's a little different than acute, of course, and there's some different things that we have to think about. But we can really rely on yoga to help change the brain. And when we think of neuroplasticity, there is, we've had folks 22 years later after their stroke who still see vast improvements due to really the combination of neuroplasticity and what it allows to happen and through the use of yoga. There's also really exciting work by Sarah Lazar on meditation, and their work has really shown that for people who meditate, we actually have increased cortical thickness and increased connectivity within the brain. And so that is great for all of us, but it's certainly really wonderful to think about for people with brain injury and stroke. And just here at CSU, we've been funded to look at brain change and brain activity for people with brain injury or traumatic brain injury after yoga. So hopefully we'll be able to do that at one point in time. We're a little challenged with COVID right now, but hopefully we'll be able to get to that and really see some changes that are occurring for folks with brain injury. So at the time when we ran our randomized control trial, there were only actually a couple of small studies about yoga and stroke, but that's how research starts, right? We start with a couple of case studies and we progress that work. And so at the time, there was a great qualitative study that really talked about the mind-body disconnect that might occur after stroke. And we'll talk more about that as we get towards the end of this talk. And then there were two different case studies that talked about just some changes that the therapists saw when they started adding yoga to their stroke clinical practice. So we ran what is still currently the largest randomized controlled trial of yoga for folks with stroke. And this was, I was at Indiana University for 8 years prior to Colorado State, and this was funded through the VA and mostly included veterans who had chronic stroke. And like I said at the beginning, here we really were focused on changing or looking to improve balance and balance self-efficacy for people with chronic stroke. We hired a yoga therapist, and the yoga therapist worked with the team to develop the intervention so that we felt like we were addressing all the needs of the clients with chronic stroke. And we really also focused on hips and ankle range of motion and strength, because there's evidence that supports improvement in strength and range of motion at those joints allows for improvement in balance. So we did focus some of our energies there. We delivered yoga twice a week for 8 weeks, and we started in sitting, but then we did get to standing, and in the pictures you can see we used chairs and the wall for standing. And then we did get to the floor. All of the floor work was done supine, and we did get to the place where we were able to do shavasana or meditation relaxation down on the floor, which if any of you do yoga, you'll know shavasana is the wonderful end of yoga, but it is not very effective, I would say, when you're sitting in a hard chair. It's very hard to get comfortable. It's just not quite the same as when we can get folks to the floor. And so people getting to the floor for many of these folks, it was the last time they were on the floor was the moment they had a stroke or the moment that they had fallen last. So there was quite an emotional response to getting down to the floor that we really had to build trust, and people had to really work with us to be able to get to the floor and feel like they were safe and safe to get off of the floor as well. So while this was a randomized controlled trial, 37 were randomized to yoga and only 10 were randomized to the wait list. And it was done purposely so that we knew we would have more people in yoga to show that it was feasible to even deliver yoga to people with chronic stroke. And you can just see here their average age in general is about 63. Their stroke was about, on average 51 months ago or more. And it was mostly men because, like I said, it was funded through the VA and it was a veteran-based study. So while we focus on balance and balance confidence, I am an occupational therapist, so I'm really excited to also tell you that we saw significant improvement in activity and participation in quality of life. And activity and participation were measured by the impact. So there's two domains, activity and participation, and then the total score. And the impact is the ICF measure of participation and activity. And then quality of life was measured by the stroke-specific quality of life scale. And so we saw significant improvement in all of these things. And I would say qualitatively, we very much heard that people got out more. They did more things. They changed their routines. They changed their life. They got on the bus. They could go to the grocery store. They went back to their place of worship. They were able to get down to the ground and play with their grandkids. And so we really saw those changes, but more importantly, we also really heard about those changes from folks in their day-to-day life. However, this was a balance and balanced self-efficacy study. So it's really important for us to, as researchers, focus here and see what changed. So you can see for the 37 people who were randomized to yoga, they had a significant improvement in their balance, but not their balance self-efficacy. Balance was measured by the Berg balance score or scale, and balance efficacy was measured by the ABC or the activity balance confidence scale. And interestingly, then we looked at the folks who really came to yoga versus the people who did not. So if they didn't come to, if they missed, I think it was about 10, if they came to less than 5 sessions, we took them out of this analysis. And so that dropped the sample to 29. But for the people who truly came to yoga, we really see some differences. So their Berg goes past 46, and 46 is the cutoff. 46 is where we say people are at risk for falls. So they actually officially cross that as a group and have a significant improvement in their balance scores. But then we also see an improvement in their balance efficacy scale. Of note though, so we see these wonderful changes in balance and balance self-efficacy, and we get really excited about that. But we also measured fall risk factor management. So thinking about fall risk, changing what they do so that they don't fall. And they had no improvement in that. So really what we found, what we heard, is that people had significant improvement in balance self-efficacy, but we actually heard that they increased their falls. And that's because they felt so much better in their body. They were doing things that maybe they shouldn't have done because they still had hemiparesis, they still had cognitive impairment, they still had a stroke. So we had people who decided, well, they should climb up on a ladder and clean out their gutters for the first time in 15 years, or went to the Indianapolis 400, 500, and walk around but fall over a bunch of tires. We heard people who went outside to do gardening but fell over their equipment. And so we learned quickly that yoga is great, but yoga is not enough. So from there, we created a new intervention that was called Got Falls, or Group Occupational Therapy for Fall Prevention. And the idea here was to really develop and test an intervention that met people's needs to figure out, okay, I had a stroke, I have a new body, I have different ways of doing things, how can I prevent falls? So this was a small pilot study. It included 10 veterans. Again, the VA funded this as well. It was a 6-week study, once a week for 2 hours. And we really focused on things like fall-proofing the house, fall-proofing the environment, doing safe exercise, and identifying fall risk factors in the house. These are the 5 assessments we use to measure fall risk factor management. So this is, we did in the yoga study, and we saw no improvement at all. And here we measure it again, and we do see some improvement. So this is just the demographics. Again, it's a age range, or the age is an average of about 65 years old, and most of them had had a stroke quite a while ago. And again, this was a totally male population because it was at the VA. So we see improvements on all of these scales, some more than others. But here, even though we included balance exercise programming and things like TheraBand and strength testing or strength development, we saw no improvement in balance or balance up efficacy. So in this study, we learned, well, OT is great, but OT is not enough. And so we really decided, okay, well, the next step has to be that we will be merging yoga and occupational therapy. And this study was funded by the AOTF intervention grants. And here we really merged what we felt like were the key elements of yoga and of the group occupational therapy or got falls intervention. And we kind of focus on the same folks, people with chronic stroke, but people who had balance impairment and who had sustained a fall. We made this an 8-week intervention, twice a week for 8 weeks to match yoga. But if you recall, got falls had been 6 weeks. So we essentially completely tore apart the got falls intervention and stretched it out to be 1 hour twice a week for 16 sessions. So I'm sorry, so it was 8 weeks, but for 16 sessions. So it wasn't much more time, but it was a better use of time because we had heard from the folks before 2 hours was just too long for processing and thinking about their falls. So in this study, they got 1 hour of education, followed by a short break, followed by 1 hour of yoga. And so we really had less homework, more in-class processing, and we made it more stroke specific. One of the activities I think is a great example of the Got Falls program that we integrated into my OT is we asked people to take a picture of where they fall commonly or where they fell last. And so someone had taken a picture of their lawnmower, and it's classic group occupational therapy process. So the group was able to say, well, what side do you get off of the lawnmower? And he said, well, my left side. But his left side was the side for his stroke, his hemiparesis. And so he fell every single time he had gotten off the lawnmower. And so the group together versus just the OT saying, do this, do that, change this, change that, through group process, the individual was able to figure out that was not the best option for him, and he could get off the lawnmower on the other side, and he sustained no more falls. So that's just a nice example, I think, of one of the many different activities that we did in the My OT intervention. So this population was a small pilot study again, but our mean age was a little older. So in the last 2 studies, the age was 63. This is about 73. This study took place in Colorado and not at the VA. So you'll see that it's a different mix of male, female, race, and even time since stroke is 77% of them, their stroke was more than 5 years ago. So we had quite a lot of folks with their stroke 20 some years ago. So it's a little different of a mix. So here though, when we really merge yoga and occupational therapy, we see some nice improvement in balance, but also balance self-efficacy and in the risk factor management scale. So all of the risk factor management for falls improve, but 2 different things improve significantly. And you can see the percent improvement, the fall prevention strategy survey improved by 42%. And that is simply a questionnaire about the frequency of how often they use their fall prevention strategies. So here they're changing their balance, their strength, their range of motion, but they're also changing their balance self-efficacy, but they're thinking more about how they can prevent their falls. So thinking about what does this mean for us as therapists, for occupational therapists, we can think, one, I always like to talk about this article just a little bit. So the idea of yoga and occupational therapy. I think this was out in 2005 from in the British Journal of Occupational Therapy. Thinking about the idea that yoga is essentially self-care and occupational therapists are experts in self-care. And we've been taught to think about people in a holistic manner, and yoga is certainly a way to do that. So that's a nice article for folks to kind of come back to. And I also think rehab therapists are really starting to use yoga as a modality in their practice. That's what happened to me as a therapist back in the clinic. I started using yoga and seeing amazing changes for people. And that's what really drove me to get my PhD and do yoga-based research. And that's what's still happening. People are finding yoga on their own and bringing it to the clinic. And so usually we do the research first, prove something works, and then it gets into clinical practice, 13, 14, 15 years later. This is a little bit opposite, where first the therapists are picking up yoga, using it, finding it works, and now we're really developing the evidence for it. We also know that there's a lot of therapists out there, OTs, PTs, rec therapists, who are now becoming yoga teachers or yoga therapists. So I myself am a yoga teacher certified at 200 hours, and I don't teach yoga, but I really wanted to better understand the clinical underpinnings or the philosophical underpinnings of yoga. One thing I wanted to make sure we talked about a little bit is the mind-body disconnect that I would say happens probably with most of the folks that we work with in rehabilitation, certainly with people with stroke, anyone with trauma. But if we think of someone with stroke specifically and their arm or their leg does not work, it does not do what they want them to do, they become angry and dismissive of that limb. And as therapists, you'll hear people say, put your bad arm in the shirt or in the sleeve, or up with the good leg, down with the bad leg. And I beg of all of us to please stop doing that, because if we keep talking about a limb as bad, it becomes bad and it becomes disconnected. I have noticed that folks with stroke often don't even know the difference between their left and right anymore. And I think it has to do with this disconnect that occurs. We also know that people really ruminate. We all ruminate, right? Things keep us up at night. Things get into our brain and get a little stuck there. For folks with stroke, a lot of those things are the past, the idea that if I didn't eat all the French fries, I wouldn't have had the stroke. If I wasn't so stressed out all the time, I would not have had the stroke. Or someday I'm going to be able to walk again. Someday I'm going to be able to pick up my kids again. Someday I'll be able to get to work again. And instead of being in the present moment, they are in the past or in the future. And I would argue that if we can help people be in the present moment, they will have enhanced recovery. It, of course, doesn't mean they're going to be the same person they were before. But I think helping them be in the present moment helps them get to whoever they are going to be again after their stroke recovery. And so I think that's a really important component of what we can do with yoga and other aspects of integrative rehabilitation practices. So other things that we think is yoga allows people to have better improvements than simple exercise. We actually have requests for their home exercise programming, which as therapists, people don't ever ask you for a home exercise program, but they actually want that for yoga. And so we don't offer it until they ask for it, because it means that it means that they're ready for it. They're going to start doing it. And it doesn't mean they're going home and doing an hour worth of yoga. People tend to pick a couple practices, postures, breath work that really resonate with them and make them feel better. And then they go home and do that. And I think that is perfect and fine. We think the mind-body connection really makes a difference. We think or know all clients can engage in at least some level of yoga, whether it's breath work, meditation. We've also run a study in inpatient rehabilitation with people with brand new strokes, spinal cord injuries, brain injuries, locked-in syndrome, and really showed that we can deliver yoga at the very earliest phases of rehabilitation, including in the ICU unit. We've done yoga in the burn ICU and the regular ICU successfully as well. We think that yoga and group occupational therapy may be complementary, but most effective when combined. We suspect dose matters, but yoga and OT and rehab in general, we still don't really know a whole lot about dose. And so people are kind of trying to look into that a little bit. We also think that yoga can be truly integrated into rehabilitation practice. So here are some tips that we have come up with for integrating yoga into practice. And Matt, who introduced us, and I are currently co-editing a book all about integrating complementary practices into rehabilitation. So this is yoga specifically, but we have done a survey, and if you would like to, the survey link is down there. We've surveyed about 200 people across the world who are therapists who use yoga in their clinical practice. And these are kind of the takeaway messages that we've heard over and over again, that really any therapist using yoga in their clinical practice really needs to have a personal yoga practice. You also need to complete some level of additional training. It doesn't necessarily mean you need to become a yoga therapist, but you need some level of training about yoga or whatever it is that you want to integrate. You have to be really thoughtful and strategic about poses. Where are you trying to get to, right? We are using yoga as a little bit of our intervention potentially, and so thinking about why we're doing what we're doing. We really like the idea of including mantras to manage self-talk. Otherwise, some of that self-talk will just be negative automatically. Again, that idea of if I didn't get into the car, or I can't do this, or I'm not succeeding, or I'm not recovering. So really use mantras to improve self-talk and make it more positive. In general, be client-centered. We're really good at this, right? OTs are really good at this. Therapists are good at this. We need to modify and meet people where they are. And I would also include that we need to be trauma sensitive. Anyone that we're seeing has had some level of trauma. That might be the stroke, that might be the car accident, it might be other variations of trauma, but to be really thoughtful and trauma sensitive with whoever we're working with. If you want to know more about yoga therapy for stroke specifically, my colleague Marika Van Pembroek and I have published the book on the left, and this is hopefully the cover for the book that Matt and I are co-editing, and he is has really brought all the authors together and the ideas together for this book, but the idea of whole person care for therapists, it has been a joy to read it. So I think it'll be a great contribution to the literature. And then I can open it up to any questions people might have.
Thank you, Dr. Schmid. That was fantastic, and an excellent launch to our webinar series that will become really an archive of evidence-based talks on complementary and integrative health in rehabilitation. The first question that we have is, what are the obstacles that you see for recruiting people who've experienced stroke or brain injury for yoga interventions?
It's a great question. I think really the big one is that people have this vision of what yoga is, and that's again, like the young, thin, white woman doing a headstand. And I get really frustrated when my work is published with one of those pictures. And so we've worked really hard to try to get, we have lots of pictures of our folks doing yoga. And so we really try to make the picture match what we're doing. And so I think if we can get through to folks that we can modify and meet them wherever they are, they can be really successful at it. I do think there's a challenge. So in my community, we actually have community-based adapted yoga, which is really amazing. But most communities don't have that. Most communities have chair yoga for seniors. And one challenge has actually been that once people have kind of learned that they can do yoga, even if it looks a little different, and do standing yoga and get to the floor and have all the benefits of floor postures, they don't really want to do that chair yoga or the senior chair yoga. And so I think we need to kind of be better about building community-based interventions that meet the needs of people, that are not overly simplified, but really meeting their needs, but still progressively challenging them.
It's great, and I'm glad that that's being addressed, because many people, I think, as a result of how yoga's, often presented in the West as this sort of rigorous physical practice, would think, well, some people think I can't do that to begin with because of those images, let alone someone who's experienced a neurological injury. So appreciate that perspective. Another question that I was curious about myself is, you mentioned this part of yoga called the yamas and niyamas, which I'd understand as being like personal ethics, personal values, sort of values for living. I'm wondering how research design can address that, or how that's included. I was thinking about how some of the studies I've seen on yoga break apart just one thing, like breathing, like a specific breathing practice, but they don't really pull it all together. And so I'm wondering if you could just say a bit about how that would be represented.
It's a great question and has really been a challenge, to be honest. So yoga is more than just the physical postures, right? Like, as we've just kind of said. So there are some people out there who would like to do yoga research of just the postures versus just the breath work. And I'm really not into that, because then it's no longer yoga, right? Then it's just physical postures. So the way we have kind of addressed the limbs, or the yamas and the niyamas, and so you're right, Matt, they're kind of the ethical standards, self-discipline, and I'm looking through some of my notes right now. What we do not, in our research studies, ever use the language of yamas or niyamas, and I suspect probably most therapists don't either. But what we instead do is kind of do examples of what, in, using only English terms, the ideas of what we are trying to move away from. And so one example is santosha, or is one of the niyamas, and that's the practice of being content. And a lot of our folks with stroke are really not content. They are really worried about future things, or they're just so distraught. And you can understand this, right? They need their time to grieve. They had a stroke, especially when you're thinking about people 40s and 50s who are having strokes. They are really challenged to be content. And so we kind of use some of our, mostly here with mantras, I would say, to practice the language a little bit, of bringing some words to them for their self-talk that they can practice on a daily basis, with or without us, to kind of to get to some of the yamas and the niyamas. But we don't ever dig deep on any of those. I would say it's quite a challenge in a study. I think the other component is, we haven't done this, but what I have thought about a lot is, in rehabilitation, particularly inpatient rehab, or if you're working in a SNF, people are essentially waiting around for you all day long, right? They're just waiting for their therapist to show up and do whatever they need to do. And so I really thought that could be, that space where they're waiting for us could be a venue where we are delivering some ideas for mental imagery, mental practice, but also some of this kind of content about being more okay with who you are, or where you are in the present moment, through audio recordings or something like that. So I think it might be hard to really embed into day-to-day yoga practice with our folks in a research study, but I think in clinical practice we can do it a little bit more, maybe, if that makes sense.
It does. That's great. Thanks, Arlene. One final question, and we're just about out of time, so maybe a quick answer on this, but there's many styles of yoga out there, and if people are looking at that, is there specific styles that you recommend to persons with disabilities?
Thanks. Yeah, I usually do say that. These are bit hatha based, so they're slower practices. That most Western yoga is based in hatha, but have then been altered or changed to be fast or vigorous. This is much more slow, with some movement with breath, but we're not moving on every breath. Our folks with stroke just can't tolerate that. So it's a pretty slow practice movement that includes movement, but then also kind of longer stretching.
Great. Thank you so much for your time. We are at the end of our time, and so we're going to be putting the word out that this is now available once the recording is up, and we'll share this far and wide so that people can hear about your research. And this is one of many ways in which complementary and integrative health is informing rehab, and really invite people to think both and, that there's a tendency to look at this either or. It's either traditional or biomedical, or it's complementary or integrative. And this is a great example of how there's this bridge building, this merging going on and that they enhance and complement each other in wonderful ways, and the research is supporting that. So thank you everyone for tuning in, and that's the end of our webinar.
Thank you, Matt. Thank you, Pei Shan.